to start?
Sure. So I'll give a brief introduction about you. We are honored to welcome you, Prof. Simon Craig, as a distinguished emergency physician from Monash Medical Center in Melbourne, as a chair of the Predict network and a leading voice in pediatric emergency research. His contributions, spanning over 130 publications and clinical texts, have shaped practice across Australia, New Zealand, and beyond. He will take us through his latest publication in July 2025 on The Lancet about the association between caregiver concerns for clinical deterioration and critical illness in children presenting to hospital, which is a prospective cohort study. So, Prof. Craig, the floor is yours.
Thank you very much for the invitation to speak with everybody here. I understand it's around midday where you are. It's 7 p.m. at night here. So it's not too late and not too inconvenient for everybody, which is lovely. This is a presentation relating to a paper that we recently had published. To start with, I just acknowledge my co-authors here, Erin Mills, who's one of my emergency physician colleagues, Phyllis Lynn's a data scientist who did a lot of the work in terms of the data extraction. Mohammed is our statistician. Adam West is my director and colleague, and I'm the other author on the paper. We don't have any financial relationships or conflicts of interest to disclose. The project was funded by a philanthropic trust called Equity Trustees and some funding from the Australian government. We have what's called a Medical Research Future Fund. Neither funding source had any input into really the study design, data collection, analysis, or the decision to publish. Where this started was the recognition that in high-income countries, critical illness in children is rare. In our institution, probably about 1 in 1,000 children have a critical procedure or critical illness when they present to the emergency department. And it's often difficult for physicians early on in a presentation to distinguish something that's pretty serious from something that's relatively minor. So often it's not until quite late in the disease process is that it's recognised. One of the things that's been demonstrated is that failure to respond to concerns from parents and caregivers has been a recurring theme in potentially preventable deaths of children. Now, within Australia, there's been a number of cases over the years that have demonstrated this. Ryan Saunders died from Group A streptococcal infection, which was not recognised at the time until it was too late. Alex was an older boy who had an infected ingrown toenail and died from sepsis. Kyron died from intussusception that was mistaken for gastroenteritis. Lachlan had a number of presentations to an emergency department and became progressively unwell before he died from sepsis. And Ashwath died from sepsis in the waiting room, or essentially in the waiting room of one of our hospitals in Perth. This isn't just an issue in Australia. Some of you may be familiar with the case of Martha Mills, who's a 13-year-old girl who was admitted to hospital with some abdominal injuries, developed sepsis and died, despite advocacy from her mother at the time. And Rory Staunton died in the US, in the state of New York, after essentially a skin infection, which then developed into sepsis. So, one of the things we know, and it is recognised, that parents who raise concerns are people that should be listened to. And many rapid response systems around the world rely on parents raising their concerns. This is the escalation path that was implemented after Ryan's death. It was the first boy that I mentioned on the other slide. So step one, if you're worried about the child's clinical condition, you speak to the nurse or doctor. If you are still worried and haven't had a satisfactory resolution, you speak to the nurse in charge. And then in the state of Queensland, where this is, there is a 1300 number, so a telephone number which you can call if you're still not concerned, or if you're still not satisfied with the response, that will lead to essentially a medical emergency team being called for an assessment independently of the clinical staff. So this parent-led escalation is embedded. However, not everybody is willing to or feels comfortable escalating. So in response to some clinical incidents at our health service at Monash in Melbourne, we introduced some proactive questioning of parents at the time of vital signs being measured by nursing staff. This was co-designed with a group of consumers, worked through a number of steps, and developed a single question. Are you worried your child is getting worse? And the idea of this was that the nursing staff, when they approached someone to do another set of vital signs, would ask this question. If the answer was yes, the concerns would be clarified, and if appropriate, then an escalation through a rapid response pathway would be done. So the aims of this paper, or this project, was really to examine the relationship between the documented caregiver concern about clinical deterioration and critical illness in children presenting to our hospital. So it was a prospective observational cohort study, conducted in where I work, the Tertiary Pediatric Emergency Department and the inpatient units of Monash Children's Hospital. It ran for a little bit over 2 years, from November 2020 to December 2022. And we've reported this according to the Strobe statement. Monash Children's Hospital is a 230-bed children's hospital in suburban Melbourne. Sees about 40,000 emergency department visits each year. We've got an on-site intensive care unit for children, and we have most subspecialties apart from a couple, burns, metabolic, and some other sort of very specialised things which are managed at another hospital in the city. For those that are unfamiliar with Australia, this is where Melbourne is, down the bottom of Australia there. If you're in the nice part of the town, this is what it looks like on a nice sunny day, and it's a little bit closer. The primary objective of this project was to examine the relationship between caregiver concern for clinical deterioration and critical illness, which we defined as being admitted to intensive care. We also had some secondary objectives to look at the relationship between caregiver concern and mechanical ventilation and death. And we also were wanting to look at how caregiver concern compared to standard predictors of deterioration, such as abnormal vital signs. So we included children aged less than 19 years. The way our emergency service works, we've got an emergency department which caters for adults, which is from 19 years and up, and the pediatric emergency department where we work looks after less than 19 years. So we'll go up to the 19th birthday. So we included everybody that was there. We looked at anyone who presented to our emergency department during this 2-year study period who had at least one documented response to the question around caregiver concern and a complete medical record available. We excluded children who'd been transferred to another hospital because we weren't able to accurately verify some of the outcomes we've interested, such as intensive care, death, and mechanical ventilation. We excluded children who did not have another set of vital signs after triage, as in they had a set of vital signs taken at the front door, they were seen and they were sent home with no further vital signs, because there was actually no opportunity for the question, are you worried your child's getting worse, to be asked with another set of vital signs. It was approved by our local research office. We'd essentially introduced the process as routine care, and we had an exemption from individual patient consent to extract the data from our electronic medical record. The data we extracted included demographic data, the Australasian triage scale category. We use a 1 to 5 categorization. So category 1 sees immediately, category 2 within 10 minutes, 3 within half an hour, 4 within an hour, and 5 up to 2 hours. So really the urgent children are going to be category 1 or 2. We looked at emergency department disposition, so home, a short stay or observation unit, or admission. We looked at hospital length of stay, intensive care admission, mechanical ventilation, and death. And we used timestamp recordings of all of the relevant vital signs as outlined there. So heart rate, respiratory rate, systolic blood pressure, oxygen saturation, and conscious state. And also the response to the caregiver concern question, which was documented in the same place as the vital signs were. We collected data for the entire hospital stay up to the point of intensive care admission, because there's not much point asking, once you're in intensive care, are you worried that you're getting worse, for an outcome of being in intensive care, which had already happened. So we classified patients as yes to the question, are you worried your child's getting worse? If they said yes at least once, we classified them as being concerned. Abnormal vital signs that met our thresholds for a medical emergency team activation on at least one occasion were considered abnormal vital signs. And we measured the time of the first set of abnormal vital signs or the time of the first yes response to caregiver concern. Just for reference, these are our cutoffs that we would use in our current system, which is based on the bona fide stuff out of Philadelphia, which sets an abnormally low heart rate, an abnormally high heart rate, and similarly for blood pressure and respiratory rate. So for a heart rate of 160 in a 1-year-old would not be considered abnormal, whereas a heart rate of 170 would be. So just recognizing that these are fairly abnormal cutoffs. But we weren't trying to find things that were a little bit abnormal, we're trying to find things that are quite abnormal. The analysis of the data was done in Stata 18 with some descriptive statistics, and really we're wanting to compare between groups. So we used Fisher's exact test for categorical variables and used regression for continuous variables and counts, as you can see there. At the end of the day, we're trying to look at the relationship between different variables. And so we did univariable logistic regression to identify unadjusted odds ratios, and then went on to adjust for the other significant factors by doing multivariable logistic regression with the adjustments that are outlined there. Recognizing that some patients may have presented more than one time, or they would have had multiple episodes of saying yes, or multiple episodes of saying abnormal vital signs, we adjusted appropriately for those things. And really the results I'll present in this way. We're going to compare those who did and didn't have the question asked. We're then going to compare those who said yes and then said no when the question was asked. Are you worried your child is getting worse? And then finally, we'll look at the predictors of the outcomes we outlined. So intensive care, mechanical ventilation, and death. So 79,000 children presented to the emergency department over the study period. After we excluded nearly 5,000 who had just a single set of triage and nothing else, and those that were transferred elsewhere, we had about 73,800 who were eligible for inclusion. However, nearly 50,000 did not have a documented response to the parent or caregiver concern question. So we're left with a data set of 24,239 individuals with at least one response that we can analyse. I understand you've got access to the paper, and I'll provide the link to the paper at the end. So I'm not going to show every line of every table in the presentation. It makes it a little bit harder to access. However, when we compared those who were asked, are you worried your child's getting worse, versus those who were not asked, what we found, it was more likely to be asked in females versus males. It was more likely to be asked in those who were disadvantaged compared to those who were advantaged. And by that, I mean socioeconomic status, which is really based on where somebody lives in terms of the average income for that region. And we have a way of dividing people into quintiles, so the lowest socioeconomic, then the next, and the highest. And we found that those were more likely to be asked if they were disadvantaged, if they were female. They were born in Australia, if they were Indigenous, so Aboriginal or Torres Strait Islander, and if they were sicker, so if they arrived by ambulance, if they had a more urgent triage category, if they had abnormal vital signs and an older conscious state, they were more likely to be asked the question. And all of these relationships were less than 0.001 on the p-value. Now, those who were asked versus not asked, again, were more likely to be admitted, having a longer length of stay, higher likelihood of intensive care, and a higher likelihood of mechanical ventilation. So we're starting to see a little bit of confounding by indication. If you are sick enough to need multiple sets of vital signs, you're more likely to be asked. But this is really the group of patients we're most interested in. So the patients who were asked were more unwell than those who were not asked. That's the first message of the paper. Now, when we asked the question, are you worried your child is getting worse? We had 4,721 parents who said yes at least once. And we had 19,518 parents who never said yes. So we're now going to look at the comparison between those who said yes and those that never said yes. Those that said yes were more likely to be younger, a median age of 3 years versus 5 years. More likely to have a higher triage category, abnormal vital signs, older conscious state, more likely to be admitted, a longer length of stay, a higher likelihood of ICU, and a higher likelihood of mechanical ventilation. So again, we've got this indication that those who are saying yes are sicker than those that are saying no. Moving on to our outcomes. An unadjusted odds ratio of 4 with confidence intervals of 3.47 to 4.72, the caregiver concern being related to intensive care unit admission. There were also significant unadjusted odds ratios for being younger. You had a lower risk the richer and more comfortable and higher socioeconomic status you had. You had a higher risk if you'd arrived by ambulance. You had a higher risk with abnormal vital signs or older conscious state. And you were higher risk if you were Aboriginal or Torres Strait Islander in unadjusted odds ratios. For mechanical ventilation, caregiver concern again had an odds ratio of greater than 4 in unadjusted odds ratios. And similarly, we had adjusted odds ratios that were unadjusted odds ratios, which are significant for ambulance arrival, abnormal vital signs, and older conscious state. So this sort of goes along with the concept that these children are sicker. And death, there was an unadjusted odds ratio of 5, but very wide confidence intervals there because of low numbers. And we had significant unadjusted odds ratios for death that were associated with a lower risk if you were English speaking, higher risk if you'd arrived by ambulance, had a higher triage category, had abnormal vital signs, or an older conscious state. So we've got these consistent messages here. But really what it comes down to is how does this relate to everything once you allow for the other associations? And this is where multivariable analysis comes in. And what we do is adjusting for all the other things I just mentioned. So adjusting for whether you came by ambulance, adjusting for whether you had abnormal vital signs, whether you had a high triage category or any of the other predictors, the adjusted odds ratio for intensive care admission was still 1.72. Adjusted odds ratio for mechanical ventilation was 1.8. Both of these were statistically significant, and you can see the span of odds ratios there does not cross 1. The adjusted odds ratio for death was not statistically significant, and it was essentially neutral at 1.02, but with very wide confidence intervals. Now, when we look at when we adjust for everything, what does that mean? Well, caregiver concern wasn't quite as strong a predictor of going to intensive care as arriving by ambulance or having an urgent triage category. So triage category 1 or 2. However, when we compare one answer of saying, yes, I'm worried my child is getting worse, compared to one abnormal heart rate, one abnormal respiratory rate, ever having an abnormal blood pressure or oxygen saturations or cold conscious state, this tells us that caregiver concern is a lot stronger, even when accounting for all these other things. So, a single yes answer regarding concern for clinical deterioration is more strongly associated with ICU admission than a single abnormal vital sign. Now, mechanical ventilation and death, well, we can just touch on. But the same message there. So intensive care admission, mechanical ventilation, even allowing for everything else, still a significant predictor of intensive care unit and death. Intensive care unit and mechanical ventilation, if the caregivers are worried their child is getting worse. Now, we had almost 1,900 presentations where we had abnormal vital signs and caregiver concern. In around 20% of these cases, or 19.3%, the caregivers found there was something wrong before the vital signs were abnormal. Another 8.7% noted the concern at the same time the vital signs were abnormal, and about three-quarters noted it after the vital signs were abnormal. So the vital signs were first. So to sort of bring this together and discuss the paper, the key findings are that the question, are you worried your child is getting worse, is simple. It's proactive. It's not reactive. It's not waiting for somebody to come and talk to us. And even after adjustment for confounding factors, there is a strong association with clinical deterioration measured by being admitted to intensive care or needing mechanical ventilation. Are you worried your child is getting worse is feasible to ask. It takes 10 seconds. And people do not say yes most of the time. So when we looked at it, it was about less than 5% of the time. So about once every 21 times we asked, somebody said yes. So most of the time, families say no. Now, over the whole presentation, about 20% of parents said yes at least once. And when you compare that to vital signs, about 26%. So you are less likely for a parent to say yes than you're going to get a set of abnormal vital signs. So you're not going to suddenly, based on our experience, be overwhelmed with a whole lot of people saying their child's getting worse. The other thing is that are you worried your child's getting worse is an opportunity for earlier recognition. And in the group of measurements where the parents recognised or were concerned before the vital signs were abnormal, the median time until the vital signs were abnormal was 7 hours, with a fair range in there, 2.4 up to 30 hours. So, putting this together, the question, we should consider incorporating this simple, cheap and feasible question into existing early warning tools. But we need to ensure that there are systems in place to adequately respond when somebody says their child's getting worse. You don't just want to record it and move on. You need to be able to react to that in an appropriate way. There are limitations in this research, as there is with all research. It's a single centre study from Melbourne. Melbourne is not necessarily the same as where you work. So there may be differences in how this is asked, how this is answered, and what implications it has. At the end of the day, we had probably around a third of patients actually responding to the question that was documented. And we've sort of pointed that out as we've gone. It was less likely to be asked for mild illness and less likely to be asked for a short emergency department visit. So there is potential for bias, including sicker children. However, they are the ones we're interested in. The other thing to note is that abnormal vital signs might actually be concerning for parents. And we note that, more than 2/3 of parents were concerned after the abnormal vital signs were noted. The thing there is that we asked the nurses to ask the question before they started doing the measurements. And of those that had abnormal vital signs, 30%, give or take, had caregiver concern. And of those who were concerned, 40% had abnormal vital signs. So there's not necessarily complete correlation. So they're possibly looking at slightly different components of what's going on. So in conclusion, the caregiver concern for clinical deterioration in their child is associated with critical illness. Parents and carers are a valuable resource in the detection of clinical deterioration and may perform better than current systems. We do need more research to confirm and extend our findings. But the bottom line is, ask the parents, are you worried your child is getting worse? And listen to their response. This paper has generated a fair bit of media interest. We were pretty excited to be told we'd made the front page of the Times in London the day after the paper was released. It's been written up in The Guardian, and this was a a podcast in a local Australian Broadcasting Corporation that was just on yesterday. Um, but really, the bottom line is very simple. And what we're doing at the moment, we have incorporated this for the last few years in our hospital, and it's continuing to be rolled out. New South Wales, which is the next state up from us, is rolling that out across the whole health services in starting in the next month or so. So it does have a potential to impact and reduce the risk of late recognition of clinical deterioration. So I'll stop there. If you haven't been able to access the paper, I'll leave the QR code up there for a little bit. And then I will happy to take questions or whatever else you would like to do in terms of discussion.
Thank you so much, Prof. Craig. Really, it's really an insightful talk and great presentation. And this study supports what many frontline clinicians have been long believed that caregivers' intuitions it matters, and it answered it simply that it has to be triggered from starting from the triad, or we have to take care of that question very carefully, even if we addressed some gray zone cases like CAT 3, like the Canadian or Australian triad score. So from there, we can take questions from the audience to Prof. Greg. There's one question from Dr. Muhammad. He's asking, what about combining all the abnormal vital signs? Did you, for example, investigate the predictive value of caregiver concern compared to combined clinical scores like Pew's?
No, thank you. It's an excellent question. Where we work in Victoria, we don't use a Pew's score. So in general, so track and trigger so activation of medical emergency teams and so on is either a simple track and trigger mechanism where you reach a threshold and a certain abnormal vital sign and that triggers, or there are combined scores such as the Pew's score. They're used in some states in Australia, but not universally, and are not used in our setting. So we did not do that. We have an honours student this year who's doing a comparison of all the different Pew's scores across Australia and the track and trigger systems that we've got. So we are yet to do an analysis which compares with
Yep.
Pew's.
Excellent, wonderful. I have another couple of questions from my side. Did caregiver concern influence triage or treatment decision? This is number one. Number two, were there differences in the impact of caregiver concern across cultures or socioeconomic groups?
Okay. So it didn't impact on triage because we didn't, well, it may have been asked at triage, but it was not documented at triage. This was designed, so triage is designed to say hello, get people on the system. The next set of vital signs is when it's meant to start because you've been triaged. And the question isn't at triage, are you worried they're getting worse? It's like, well, you've been here for a while. Now, are you worried they're getting worse? So we're trying to pick up deterioration after triage. So it would not have impacted on the triage decision itself. With regards to did caregiver concern drive care, it was meant to drive care in that it was part of our hospital's improvement program to try and identify or help identify patients that we weren't identifying. So what was meant to happen when somebody said, yes, I'm worried, what was supposed to happen was the nurse was meant to clarify that the worry was not the child's hungry, the child's cold, the child wants another blanket. If there was a concern that was actually, we're worried the child is getting worse, then they would notify the treating doctor. The treating doctor would then go to the bedside and do what needed to be done. So we didn't, this was also be the case if somebody developed abnormal vital signs in another way. So if they became tachycardic, the nurse would go to the doctor and ask the doctor to go to the bedside and do that. So it didn't drive treatment. We didn't say, okay, everyone who the caregiver concerned, we're now going to call ICU or give them a fluid bolus or anything like that. It was more if there is concern by the caregiver, they need an appropriate assessment and then treatment would flow from that. With regards to ethnicity and socioeconomic status, we did not find there was a difference So from an ethnicity point of view, Australia doesn't do a great job of capturing ethnicity at an administrative level. What we found, what we do usually is whether somebody is born overseas, born as an Aboriginal or Torres Strait Islander, and that's it. So there's not a sort of a nuanced analysis. We are yet to do, but we are planning a subgroup analysis of those that are noted to speak English or need an interpreter versus those that don't, to try and sort of tease out some of those communication issues. Socioeconomic status didn't come out as a separate predictor in the multivariable analysis. So it did not seem to predict ICU or anything by the time we got down to multivariate analysis. There was no difference between the different
Mhm.
groups. So I
Wonderful,
think I
perfect.
answered all of those questions there.
Okay. So another question by Dr. Khamis asking you that did you control for co-founders like pre-existing chronic illnesses, which might influence both concern and outcome, which is really a great question.
So we do not have a standard way of capturing chronic disease in the electronic medical record in a way that's easily extractable. So we did not control for that. However, the recognition that parents who have kids who are chronically unwell or have chronic diseases are probably the best people in the world to identify whether their child is different to usual. The kids who are technology dependent, the kids who have, severe cerebral palsy or profoundly disabled, the parents know probably better than we do when their child's different, when their child's getting worse, and so on. So trying to listen to their voice is important. Doing a subgroup analysis on those with existing chronic illnesses or significant disability is part of the future directions of this work, but that we've been sort of constrained somewhat by what's actually in our medical record at the time.
Okay, wonderful. There's another question by Dr. Ramla. What was the percentage of deteriorated patients whom the answer to that question was no? I bet you have answered that question in your presentation.
Yeah, no, I'll just we'll do the maths just to be sure. So we had 4,721 people that said yes. And of those, 326 went to intensive care.
Mm.
So overall, for that, it was 6.9% of children who said yes went to intensive care. Of those that said no, we had 19,518 and we had 352 going to intensive care. So it was 1.8% versus 6.9%. It's about a 4 times difference, which is where you get that unadjusted odds ratio from. So yes, you're more likely to go to ICU if someone said yes.
Perfect. There's another question by Dr. Robert. He's thanking you for your amazing talk and presentation. However, he's asking were there a specific vital sign that triggered the families to raise their concern, and his meaning by specific vital sign, statistical significant vital sign.
I might, so as in, were they more likely to raise their concerns if there was tachycardia versus tachypnea versus conscious state? I can't tell you the answer to that. We didn't necessarily, so we looked at whether they were independent predictors when accounting for other things, but we didn't look at relationships between one vital sign and another and concern. But that's an interesting question, but we don't have that data at this stage.
Okay,
And
wonderful.
I can see the chat, and there's another question about parents working in the health sector. We do not have information on the employment status of the parents, which parent was answering the question. It was literally a box in the medical record which said caregiver concern, yes, no, and that was it. So I can't tell you anything about the parents, unfortunately. But from a health system point of view, we would have a proportion of people that are healthcare workers, but not a great proportion. In Australia, it's a publicly funded healthcare system where presentation to the emergency department is available to everybody. healthcare workers make up probably, a couple of percent of the population overall. So I don't think they would be, when a private hospital, there's no financial or other barriers to coming in looking for care. So I don't think that there will be a disproportionate number of healthcare workers that would sort of push one way or the other. But no, we don't have detail. We don't have very much information on the parents, whether it was the mother, the father, the grandfather, the uncle, we don't know. We just asked the question. We didn't get too much on the characteristics of the people answering it.
Wonderful. I think we came up to a conclusion, Dr. Craig, that caregiver concerns, it has to become biggest vital signs, let's say the sixth vital signs in our triad. I think this is a great thing to be had in such second paper or a future paper. And again, finally, I would love to thank you again for giving us your time, giving us this insightful talk and presentation with that conclusion. And by that, I really thank you so much for your night time, and good night for you from the other side of Australia, and good afternoon for us in Saudi Arabia, Riyadh. And any last words from your side, Prof. Craig?
Oh, no, thank you very much for the opportunity to speak with you. Very happy to continue to discuss, or if you've got any further questions or concerns about the paper. We're doing a whole lot of additional work at the moment. The question's been also asked in the adult population. We're doing a project on that. We are trying to compare how this integrates with pews and those sorts of things. And we're also in the process of developing a little smartphone app which will push the question to the family's smartphone, which will then ask them, and then we're going to try and hope to link that to the medical record. So again, to try and understand a little bit more how that all works. So,
Yes.
it's an interesting concept, and we're in a sort of a unique position to try and look at it. But doing this in other places is really important. And thank you so much again for the invitation.
Thank you so much, and see you in another collaboration soon. Thank you so much, Prof. Craig, and have a good
Okay.
night.
Thank you.
Bye.